Just be happy with who you are. Just be happy with who you are. Just be happy with who you are.
Hi, and now we're going to look at substance-related and addictive disorder. Now, throughout the evening of June 24, 2009, that might be an important date for some of you, Michael Jackson, the entertainer, energetically rehearsed for an upcoming concert series. The next morning, he was found in his bedroom, not breathing. Paramedics could not revive him. His death appeared to be a result of a drug overdose. Battling pain, anxiety, and chronic insomnia, Jackson used a variety of pain medications. His addiction reportedly began with pain medication prescribed after he was burned while filming a Pepsi commercial. The details of his later drug use were unclear, but prescription killers, stimulants, and anti-anxiety and sleeping medications were often mentioned. Medication became less effective as Jackson developed tolerance to the drugs. Jackson continued to battle chronic insomnia and was desperate for rest, resorting to an increasingly more dangerous substances, and on June 25, 2009, he suffered a cardiac arrest. The coroner found multiple medications in Jackson's system, including a powerful anesthesiac, propofol. It was concluded that Jackson's death resulted from acute propofol intoxication. Addiction of alcohol and substances are something new to us. Aren't something new to us. However, they can and do create the circumstances by which we can struggle with and be able to participate normally in our lives. Let's see how this form of disorder is classified, described, and theoretical perspectives and treatment strategies related to substance-related and addictive disorder. So looking at classification related to the addictive disorder, the DSM-5 classifies substance-related disorders into two major groups: substance use disorders and substance-induced disorders. Substance use disorders involve maladaptive use of psychoactive substances. Substance-induced disorders are disorders induced by the use of psychoactive substances, including intoxication, withdrawal syndrome, mood disorders, delirium, and delirium tremens, and even amnesia. So let's review some of the terms. Mood disorders and amnesia are going to be covered in chapters 4 and 5. Okay, intoxication. This is characterized by clinically problematic behavior or psychological changes that caused by a recent ingestion of a substance. In other words, it's the state of drunkenness or being high. What intoxication will look like depends on the substance, the dosage, a person's reactivity, and to some degree the user's expectations. Extreme intoxication can lead to death. Now, withdrawal syndrome, the characteristics when a person stops a substance they're using abruptly after a long and heavy use. The symptoms will vary according to substance abused, but often people who do suddenly stop will start up again, as the resulting withdrawal can be extremely uncomfortable. Therefore, starting to use again relieves the discomfort. With alcohol, withdrawal can include delirium and delirium tremens, or the DTs. Delirium, a state of confusion. There tend to be incoherent speech, disorientation, even hallucinations. The delirium tremens usually are associated with heavy chronic users of alcohol who stop abruptly. DTs involve autonomic hyperactivity, tachycardia or rapid heart rate, and improve sweating and delirium, a very uncomfortable state. So when we consider the substance use disorder, according to the DSM-5, Substance use disorder involves a pattern of recurrent use of the substance that repeatedly leads to damaging consequences to social, occupational, psychological, or physical problems. Substance use disorder, which often includes features of physiological dependence and involves impaired control over the use of the substance. You don't know when to stop or how much you've taken. Substance use disorder may continue over a long period and can progress to more severe progression, even to feeling helpless to control the use. Addiction, physiological dependence, and psychological dependence. Now, these are important terms and ones that can help with treatment. People define addiction in different ways. For our purpose, we define it as the habitual or compulsive use of a drug accompanied by evidence of physiological dependence. The major sign of physiological dependence involves the development of tolerance and or an abstinence syndrome. You may have experienced tolerance if you were prescribed a pain medication after surgery and you took the medication as prescribed. Perhaps after a while, you notice the medication may not have had the same effect. This could be, or it could resemble, tolerance. Psychological dependence. This involves a pattern of compulsive use associated with impaired control over the use of the drug. Now, this dependence can be a tricky one, especially with treatments. We may get a point where physiologically the substance and its effect have cleared our system. However, we may still find hanging out with someone of our friends who was using or going to a place where we used to go before, and this can oftentimes trigger a psychological trigger that activates our use again. So if I've been an alcoholic, or if I've been a user of drugs and I walk past a place that has normally been a place that I would go to drink or to use drugs, my walking past that place while I've stopped might act as a psychological trigger where I feel myself, I'll go in, and what will one drink do? And the next thing you know, you're back where you were. They are not physical. They are more related to our thinking. That's why they would be called like a trigger in this thing, our thinking trigger. Like for those who have stopped smoking or going to a bar or a restaurant can be difficult, as your friend goes out for a smoke or after a meal you want to go out, and because you used to do that same thing, this can only be more challenging than you think, or this can be more challenging than you think. Now, pathways. How do we get to substance use disorder? Now, although the progression to substance use disorder varies from person to person, some common pathways can be described. And according to the following stages: experimentation. This is the occasional use, temporarily you get that feel good from the alcohol or the drugs. The user feels in control. I can go home, sleep it off, and the next day is the next day and I'll be fine. And believes they can stop at any time. I could stop this if I wanted to, I just don't want to. That's the first stage, experimentation. The second stage is routine use. Lives begin to be structured around the pursuit and or use of drugs. Denial plays a big role here, or covering up. Things that were once important, family or work, are less so than the drugs. Choices are dominated by drugs, spending, straining of relationships with friends and family, unexplained absences play. This is that second role. And then addiction or dependence. This is when a routine user feels powerless to resist the drug, either its effects of the drug or just to avoid the withdrawal. So drugs of abuse. And here we're going to look at classification of substance-related disorders. There are three groupings. There's first depressants, stimulants, and lastly hallucinogens. And we'll start with depressants. Depressants are drugs that lower the level of activity of the central nervous system by reducing feelings of tension and anxiety, causes movements to become sluggish, and impairs cognitive processes. In high doses, depressants can arrest vital functions and cause death. Depressants include alcohol, barbiturates, sedatives, and minor tranquilizers and opioids. The effects of alcohol include intoxication, impaired coordination, slurred speech, and impaired intellectual functioning. The risks for alcoholism, well, gender, there is equality here. Fair and equal. There is some dispute that may be due to, when studies were completed, women started later, but alcoholism moves more quickly for women, but it's an equal opportunity disorder. Age, young adults before the age of 40, and typically beginning in late adolescence, somewhat later for women, is one of the issues. Antisocial personality disorder. Antisocial personality disorder, the antisocial behavior in adolescence and adulthood increases the risk for alcoholism later. And family history can certainly play a role. The best predictor for problem drinking in adulthood, this could be a result of poor modeling and perhaps some biological predisposition. You remember when we talked about the interpersonal perspective, the diathos stress model, a predisposition. And then some of the socio-demographic information, increased risk for lower income with alcoholism. Education level contributes, and education level contributes to higher risks for alcoholism. Now, concepts of alcoholism include the once an alcohol, always an alcoholic. Now, this was Jelinek's disease model. The psychological effects, often the stereotypical expectation that alcohol will reduce tensions and worries and increase pleasure in social interactions, in fact can be more detrimental. The short-term pleasure, long-term pain effect. And what I mean by that is the alcohol can give you this short-term pleasure of feeling confident and feeling socially engaged, but the long-term pain associated with continued use is alcoholism. Now, chronic disordered alcohol use can be connected with disorders such as alcohol-induced persisting amnesia disorder, aka Korsakoff's syndrome, cirrhosis of the liver, or other physical disorders, and with fetal alcohol syndrome. Barbiturates are depressants or sedatives that have been used medically for relief of anxiety and short-term insomnia, among other uses. They can become psychologically and physiologically dependent in both in terms of tolerance and in the development of withdrawal symptoms. Now, opioids are narcotics, such as morphine and heroin, and they're derived from the opium poppy. Others are more synthesized, used medically for relief of pain and analgesia, and these are strongly addictive. The disease model treats problems of substance abuse and dependence as disease processes. Now we'll go to stimulants. Stimulants increase the activity of the nervous system. Psychoactive substances like amphetamines and cocaine increase the availability of neurotransmitters in the brain, heightening states of arousal. High doses can produce an amphetamine psychosis, which mimics features of paranoid schizophrenia. Cocaine, which is produced from the cacao leaves, is snorted as a powder or injected as a liquid, freebasing, or smoked in a hardened form, which would be crack. Cocaine produces a high but stimulating. Cocaine produces a high by stimulating the neurotransmitter dopamine, resulting in a rise in blood pressure, accelerated heart rate, reduced blood flow to the heart. Overdosing of it can include insomnia, restlessness, nausea, tremors, hallucinations, and even death. Now, repeated use of nicotine, usually in the form of cigarettes, can lead to physiological dependence. Now, any of us who have been smokers know about that. Hallucinogens are also known as psychedelics, are a class of drug that produces sensory distortions or hallucinations. Hallucinations involve major alterations in color perception, hearing. Hallucinations may also have an additional effect such as relaxation and euphoria, in some cases panic. Hallucinogens include LSD, psilocybin, and mescaline. Other drugs with similar effects are cannabis or marijuana and phencyclidine, PCP. There is little evidence that these drugs induce physiological dependence, although psychological dependency may occur. Excuse me. LSD is an acronym for lysergic acid diethylamide. It appears to describe the I'm going to repeat that because I think I just tripped all over my words and lost my spot. So the LSD is an acronym for lysergic acid diethylamide, and it appears to decrease the serotonin action and increase the dopamine activities. Flashbacks or the re-experiencing of some of the distortions from a trip can happen days, months, even years after use. They are sudden and as a result of chemical changes in the brain. PCB or psilocybin, it began as an anesthetic in the 50s and was discontinued when discovered its hallucinatory effects. Very unpredictable effects, which can verily increase the heart rates and blood pressure, but also capable of producing states of delirium. Marijuana as a psychoactive ingredient has a psychoactive ingredient called THC, or delta-9 tetrahydrocannabinol. The proportion of marijuana users in Canada is much higher among young adults than in the proportion as a whole. Dependence on is associated with psychological and physiological dependence. Then there's inhalants. Inhalants are substances that produce chemical vapor that are inhaled for its psychoactive effect. Many substances can produce fumes which, when inhaled, can induce feelings of intoxication and euphoria by their actions on the GABA and the dopamine systems. The psychological and physical effects of inhalants can be very serious, even ones that can even be fatal on one use. Now, I know this was really just a quick overview of the classifications of substance, but next we're going to consider the theoretical perspectives in part 2. All right, carry on. Watch part 2.